Welcome to everybody, and thanks to everybody for all that you've done to make this possible. This started back when Roger Glass asked me to see if we could meet on the big screen, and I said I would give it a try, but that I was sure that it would be more interesting for folks back home to hear from the students than to hear from me. So what I've done is brought an amazing group of young people here who are going to talk with you about the work that we've been doing, that they've been able to do as part of a program here at the medical school. It's a problem-based curriculum, and the program is called COBES, which focuses on community service. And the students take part in community service by doing residencies every year for the course of their medical training. I'd really like to say hello, if he's listening, and thanks to Dr. Donald Lindbergh, Dr. Roger Glass, Dean Nelson Sewan-Kambo from here at the Faculty of Medicine, Dean Stephen Kajambu from the Faculty of Medicine here, Dr. Andrew Mwanika, who is actually with us today in this space. Dr. Mwanika is director of the COPES program, so if you have any questions, he can speak to things as well. And of course, the Mufumi project. Mufumi Village is a small village outside of Tororo in the eastern part of the country, where the students have been doing a lot of interesting field work. I should say that I guess everybody probably knows who I am. I've not said that. I'm Julia Royal, Chief of International Programs at the National Library of Medicine in the US. And I'm a Fulbright Scholar here in Uganda for 2007-2008. And I'm going to be, well, we've done a lot of very interesting work here. One project focused in particular on this village in the eastern part of the country. We've done a baseline, the students have carried out a baseline survey there on the knowledge people have about malaria. And then we've sought to explore that age-old question of, can information and an IT intervention make a difference in the morbidity and mortality of malaria? Well, we're not here to give you the final call on that one, but we're here to talk about the process of taking information directly to the people based on conversations that they have had about their ideas, their thoughts, and how we put what we hear from them together with what we know on the medical end to create an information intervention that can be really helpful on the grassroots level. There's a lot more to be said about all of that, and I'm hoping this is just the first of several video conferences that we can have together. Also here today is a colleague from the US, Chris Conti, who's here on a fellowship, a journalism fellowship. And Chris is with the New Vision, one of our daily newspapers here, and he is here to hear the students, but also he's brought a reporter with him, so we're delighted to have them with us as well. I'll start things off here by first giving you, those of you that have an agenda, you know that there are several students who are going to speak about different pieces of the work, and I wanted to just begin with introducing William Lubega. William is going to talk about, his interest has been in anthropology and medicine. And he's been very interested in what you can learn by listening to the voice of the community, what we can learn. So I'm going to pass the mic to William, and then they're in turn going to introduce one another. So over to you, William.
Thank you, Julia. My name is Lubega William. I'm a fourth-year medical student. I've been.
Yes.
Yeah. Hey, Julia. I just want you to know.
Julie's here.
Julia, I want you to know who you're speaking to. Can you hear me?
Yes. I can hear you. I can't really see you.
This is Julia. This is Roger Glass.
Hey,
Julia, this is
Roger.
and I just want you to know we have a half a dozen people from Fogarty who are listening to you on this side, including Sonia Madera, who's our project officer for Africa, and we have a visitor from Kenya, Onesmo Olemoyo, from Isepe in Nairobi. So we have an African on our side to match your American on that side. So we're all listening with great interest and intent. And I just wanted your students to know how enthusiastic and excited we are to see you sitting there with your smile on your face, and know that we're listening to you with great interest. So I just wanted to interrupt for a second to tell you that.
Thank you, Roger. I can hear you loud and clear. I can kind of sort of tell that there are people in the room. But hello to everyone, and thank you for coming. After the students talk, please feel free to interact with questions. Please tell them who you are. They're very interested in knowing you as well. So thanks, Roger, I appreciate it. And Jambo, to our friend from Kenya.
Hello, everyone out there. My name is Lwega William. I'm a fourth-year medical student. I've been privileged to work with this project, which is basically on the Baseline Plus African tutorials. Hope all of you have had a look at this, or probably look at the web link. So the African tutorials were designed with the community's health needs as the yardstick. So all these interventions, like for example, the tutorial on malaria, it was designed from the community. So what we did, as Julia mentioned, the COPS program, which COPS program is a community-based education and service program whereby medical students got into rural settings in the villages for a residence of about 5 to 6 weeks. They live with the community, they eat with the community, they work with the community to find common solutions. And what the students are expected in the end is to come up with a community diagnosis report. And these reports, they are compiled, and the disease priorities in these communities were determined. And so with the different diseases, we came up with malaria, diarrhea, malnutrition. Most of you are aware that malaria, for example, in Uganda, kills over 40,000 children every year. And we have also diarrhea, which is a really very killer disease in the rural kind of setting, whereby over 30,000 children die. So within the community, we found the solutions to some of the problems that the community faced. And one important thing that we noticed was the knowledge, the information that's within the community, what's the perspectives of the people in the community. Like, for example, I'll give you some of the common myths which are out there in the community. Like, I was in a village in Eastern Tororo where people thought that mangoes cause malaria. But in most cases, the health professionals, the people from the West, they'll completely think it's ridiculous for someone to think that mangoes cause malaria. But this is what the people think. So despite all the health education campaigns by the Ministry of Health, the different health talks on the radios, people still have these common myths. So what we did when we were designing the tutorials, we didn't rubbish off these common beliefs, but we took them into consideration and we incorporated them in the tutorials that we designed. So in most cases, in order for these health interventions to be sustainable, they need to have the community as a main partner. The community has to be a partner in these health interventions. So in order for these health interventions to be sustainable, we try as much as possible to include the community at all levels in developing the products, in proofreading the products. We incorporate the myths that these people have, their knowledge, And we also add an aspect of cultural sensitivity. So that's why when you try out these tutorials in the community, they are more acceptable in the community because the community feels that they belong to them and they are derived from within the community. So I'd like to pass this opportunity on to my next colleague, Chigudu Thomas, who will tell you about what people know about malaria and the baseline survey we did in Eastern Terra. Thank you very much.
I'm so glad to actually come here and talk to such people like you. First of all, I must greet you, whatever, I don't know what time zone is there right now, but... It's there. Okay. My subject, as I has told you, was baseline survey of what people think or what they know about malaria. And again, I must tell you that I was privileged to take part into this survey, which we did sometime back in the last year. This was, I think, when was it? Around July? Yeah, July. And we found out so much that people know, and we thought that what we knew is not what they know, although sometimes you find out that when you visit these communities, definitely, you may think that what you know is what they know. But in the end, as I might say that, I'm a Ugandan, and I've been able to live in Uganda, for example, for all this time. So I've lived both in communities that are poor and those that are rich, or I would say that are privileged and those which are not privileged. But again, I must say that education, culture, or beliefs is the core of what people know or understand about malaria. Those who have gone to school understand better than those who have not gone to school, and vice versa. So what we found out really around this time is that, first, you talk to people who have gone to school and they know that yes, malaria is caused by mosquitoes. And it's a fact. Everyone knows that malaria is caused by mosquitoes. I want to go through the scientific of the parasites that may be carried by these mosquitoes, but they do know that malaria is caused by mosquitoes. That's the main thing which we found out. Although you kind of find that other people that are very much in the deep villages, I think otherwise. So we went into a survey thinking that we are going to get these answers, and we got them. Some of these, as my colleague has told you, that people think mangoes cause malaria. But they may be right if you look in their own perspective of these things. First, the mangoes come during the rainy season. I must tell you that whenever it rains, water is locked in some places. And this is a good harbor for mosquitoes to breed. So when someone tells you that malaria is caused by mangoes, you may think he's right. But because he didn't go to school, or perhaps he has not been taught by people like us who have gone to school, probably he's going to take that message on to even to next people. So we went in to say that if they do believe that mangoes, which come in the rainy season, are causing malaria. But again, we also found out that these people do believe that it's the dirty water which causes malaria in some areas. Dirty water meaning that because they're living under swamps, we did it in Mufumi, as he has told you. Mufumi is, I must say, underprivileged to some extent. It's made of poor people. People who get water from swamps, people who have just started getting tap water. So when they tell you that it's got from that water, you also don't negate that subject. Because you know that they're getting swamp water, and whenever they go to swamp water, they're liable to be bitten by these mosquitoes. Another thing which I also found out was funny is that people believe that when you're not hygienic enough, you're going to get malaria. If you don't sweep your compound, if you don't bathe, if you don't brush your teeth, if you don't drink unboiled water, that's all causing you malaria. But this, I want to expound on that. These people know that when you do certain things, because I think because many health workers have gone there and have kind of brought out the subject, you must be hygienic. And to be hygienic definitely means that you must sweep your compounds, and that means you must clear the compound of any substance or object that may harbor water that may breed mosquitoes. So in that way, you're also seeing that they have the point home, but do they understand what really causes malaria? That was the issue. So our main focus was on that person. What do they believe? And some of these myths they have. Actually, when you look into, as I've told you, they are right. They are right. Because if I tell you the rainy season causes malaria, you see, we have more water in the rainy season. If I tell you you have more fruits in the rainy season, yes, we have more fruits in the rainy season. If I tell you you don't that water, you get
That amendment?
I'm
But
terribly
that-
sorry, they seem to have lost contact with the CIT bridge.
Okay.
Give it a moment, they'll reconnect. They did this once during testing.
Can you hear me?
You're back out of this now.
Okay. Yes, I talked about mints. I haven't forgotten about the issue of bushes. It's okay? I talked about the issue of bushes. Bushes, everyone knows that mosquitoes are always in the bushes after breeding. So that's where they come from and enter our houses. And these people know. Because again, they've been told by other people who have gone in these communities. Thank God to some of these projects that have been there, the Mufumi project. But that doesn't mean that if they know that bushes, and they are clearing them, some of them, and they know that if you clear these bushes, you're going to eliminate mosquitoes. But we're asking ourselves, yes, if you clear the bushes, then what? Then what? That's when I went to another point, which was to find out that where do people go and how do they know that they have got malaria? And everyone will tell you that if my child is sick or has got malaria, is having fevers, is having high temperatures, is not feeding as usual, is not playing as usual. And these are the common symptoms or clinical features we see with malaria. And they are right. Only that they cannot really put forward the issue that this is malaria and this is how we're going to prevent. And also some of them know that when you go to the hospital, you get drugs. And we were so surprised in our study that even if these are people from the rural villages, who would think or we thought that really take much into the issue of herbal doctors, or we shall say herbal remedies. We are surprised this community is not so much into herbal medicine. I have to really cut short of this, but the point home is that people know what malaria is. Our main challenge is to tell them how it comes about and what to do to prevent it. Thank you very much. Sorry about that. I have to introduce my next colleague, who's Nixon Nyonzima. He's also a fourth-year medical student here at Makerere University.
Thank you very much. Like you've heard, my name is Nixon Nyonzima, and I'm talking about patient education. And in particular reference, I'll talk about the Mifumi project, Mifumi Health Center 4. Now, I believe in preventive medicine, the most important thing is not the lack of knowledge, but rather translation of this knowledge that we have. For we have a very, very vast database of knowledge about disease, about illnesses. But the problem is translation of this knowledge into something that the patient or the end consumer
I don't know if anybody can hear me in any of the ends, but we're stuck in a freeze frame. So that's what I look like.
Frozen.
Yeah.
Well, you're smiling, at least.
I believe there's connectivity problems between Uganda and here. I can't tell you where, but hopefully they'll reconnect in another moment.
Thanks, Frank. By the way, they have some more speakers. What that means is that they may go well after 9:30. I know a lot of us have got to go exactly 9:30. I'm one of them. So if anybody's here after that point, anybody's around after 9:35, you want to come up and say goodbye, that would be deeply appreciated. Because I know that several of us have got to go.
We stay.
Can you hear us over there? Hey, NLM, can you
Yes,
hear us?
yes, we can hear you, Dr. Glass. No
This,
problem.
I must say, while we're waiting, this is fabulous to hear these kids see what Julia's done.
Oh,
So,
sure.
you know, if we get the bugs out of the computer or whatever, out of the cable, it would be great. We actually have Onesmo Olemoy from ISEPE in outside Nairobi, who's going to be speaking at 10 o'clock at the Stone House about community control and malaria. Onesmo was a classmate of mine in medical school, so we go way back, and he's stuck with malaria for 30 years or so and other insect-borne diseases. So I don't know if you can see us. Can you see us there?
Yes, we can. Yes, we can. It's not as clear as it should be, but it's still watchable.
Okay, and you see Onesmo is right
We do.
next to me.
We do. We see it. I think we do, don't we? Okay. Yeah. Okay. And anyway, when the connection works, it works fine. So put it that way. It's certainly highly watchable, and it is always much better to listen directly from the sources, I think. So.
CIT is handling the connection.
Yes, that's right, Dr. Jones.
Yeah.
And
This split screen.
And the folks here think the problem is in Kampala, but we're not sure.
Okay.
So they're also listening and watching videos.
Yeah.
So
So actually, Julia belongs to them.
well, it's, yes, I also.
Not only that, we share the same office.
I very much enjoyed your Board of Regents meeting the other day. It was a wonderful group of people and good discussions of common interest.
Well, we certainly thank you for coming and talking about Fogarty. I think to a lot of people, even the people from NLM, what you said was certainly of interest to them. And I don't think there's been someone from Fogarty attend a board meeting like that in some time. So I think it was very good to have an update.
We also have Tom Willems here from NIAID, who's the malaria guru over there, intramurally, I guess. Is that fair? Is that the proper term?
Well, we're
Guru?
guru. Probably not. But basic science in the malaria at Twin Brook, and we also have a strong field program in Mali and a developing program in Cambodia. So this is very interesting to me. I think this is very important.
Yeah.
To be out in the community and connecting this way. I'm enjoying very much hearing what the Ugandans are doing.
Can you hear him?
Yeah, sure, no problem. You're perfectly. Actually, from the NLM side, we have a couple people in the room who are the key people or two of the key people in our consumer health informatics service, Medline Plus, including some of the people who put the malaria pages together. And we have a couple people in the room who are also very much involved in our connection with libraries around the rest of the country. And we have a couple other people here as well, who are just interested in the topic.
I also think the topic that Julia's chosen of actually getting the community to participate in malaria control is clearly a very important one, and one which does not come out on campus in biomedical science. And we think so much about the biology of the mosquito and the genetics of the mosquito and the disease itself, that what people actually think out there, which is critical for control, is something that we're really ill-prepared to deal with. It has to be done with a Swahili speaker in a local community who can go out and rub shoulders and actually make these observations. So I think the exercise that Julia is going through, and the book that group produced on malaria, is really a wonderful experience. It's really a wonderful training experience. It'd be a great training experience for American medical students too.
One of the modules that
Come over here and talk, Aaron.
one of the modules that I teach in my medical anthropology course at USIS is etiology of disease and what people really think the etiology is when it's something else.
This is Tom Willems again. we've known Julia for a number of years. She and I have met each other maybe 15 years ago through different conferences and them and the like. Talked about this issue from time to time. It's been tremendously educational for me to work with the Dogon and group along the Niger River and Mali. It's again hearing the views of the traditional practitioners, the traditional healers there, and the village chiefs and the approach to malaria. I agree completely that going out and rubbing shoulders and eating and working and staying in the village with the people turns your perspective to the important issues. We went there, we go there often, we send students there who have the biomedical, molecular biology, molecular medicine education coming from the United States. And I think the educational experience for them, they often go with the idea that they're going to teach, but I think they come back thinking that I have so much more to learn about malaria.
I think we're back on. I think we're back.
Hey, you're back on.
I'm sorry for the unfortunate course of events. I don't know if I'm the cause or, but I'm sorry. I was talking about packaging information to be consumed by the end user, information that can be easily understood by the layman. And I was giving the example of the malaria tool we had. Now initially we have so much medical knowledge.
Getting a lot of exercise.
I'm supposed to be meeting with Joyce from 9 to 10, so
I see we have the same problem.
if it comes back on, I'm not gonna.
I'm terribly sorry.
I can have somebody else do it, or.
I don't know
Or is it-
I don't know where the signal is being lost. If it's just not a
I mean,
good signal,
It was Linda.
Yeah,
I'd
if
let
it's
her know.
satellite or
Yeah, I'd like to
hardline
every
or
day.
what.
Sure, I've all kinds
I just
of
wanna make
I
problems.
just wanna make
But-
sure you can stay.
If you see poverty, it means that it's not on our end.
Yeah.
Um,
Corey, could they hear that at Fogarty, what you just said?
Yeah, we can hear you.
Okay, fine.
We don't see them.
Okay, we believe that the problem is at their end. Of course, it could be in a satellite, it could be in their computer system, it could be, there's probably 15 or 20 different gremlins that could cause this problem. But if we're seeing each other, that means that it has to probably be between Kampala and the hookup also. The only thing I
You
could,
know, while we're waiting, I might introduce Onesmo and let him say something until the screen gets back on, because he's our Fogarty visiting scholar for the day to talk about malaria.
go right ahead.
Well,
she's worked with before, so.
He can hear you, he can see you.
yes. Well, I feel very privileged to be here. I will be talking about malaria this morning at the Fogarty.
You know.
I have known Julia for 4 or 5 years actually, because
Yeah.
she was instrumental in setting up the communications for center on the shores of Lake Victoria. It is a research laboratory which is embedded right in the center of a hollow endemic area. And she set this whole thing up so that our scientists who work in that center could communicate with the rest of the world. And that was an extremely important contribution that she did. What they're doing with communities, I think, is absolutely critical in any interventions that can be put in place to control malaria. It's one thing to discover a drug or some other intervention for controlling malaria. It's entirely another one to actually take it to the community and to convince them that this is something they need to take up. And it's only by doing that that interventions become sustainable. And I'll be talking about some of these this morning. So this is an extremely important thing to be doing. And it does not only apply to malaria, it applies to many of the other diseases that the people who have malaria also suffer from. And I'm thinking specifically of the core infections that one sees that people who have malaria also get. The gastrointestinal parasites in particular, which also cause anemia. So what they're doing with the community and community education is very, very important. But that education is actually a two-way process. There is a great deal to be learned by finding out what the communities know about whatever disease one is interested in. And I'll mention in passing that the Nobel Prize was given in 1903 to Sir Ross. And it actually turns out that in certain groups in East Africa, the name for malaria is the same name as mosquito, which suggests that for some time it has been known that the mosquitoes transmit the fever disease, is what is called in some of these groups, which is very interesting. So, trying to find out what people know and what they don't know, and what you think you can convince them to participate in interventions is very important.
Well, the only thing I'd say from this end, and thank you very much for your remarks, by the way, is one of the motifs that you've been talking about. Again, the focus today obviously is global health and specifically in Africa, but so many of the lessons that we've been describing back and forth happen to be very much true in the delivery of better health care in medically underserved audiences in the United States, in North America. Those of us who work with, particularly with Native American groups, that many of us have here, many of the lessons that you discussed are also very much the case. And again, there are differences, and they're more than subtle, but nevertheless, the interesting thing is that many of the lessons that we can learn about getting community support, community education, getting people out to communities, working with people one-on-one, that's very much true in some areas as well in North America. And although we don't like to talk about that very much. Are we back on?
We don't see her.
Yes, we are.
Okay, we're back on between the two, and inside of NIH. By the way, we see you much better now. When you moved in to focus on it, it was very helpful.
So I was saying that
They're back up, they can hear.
we have the okay. So we have the malaria project in Nufumi, and well, our end aim is to make the patient understand, to make the end consumer understand our message, and we need to see a change in their actions, their behavior, and of course this is a process, and a process leading to the patient understanding the medical information that we have. So we need to translate this message into something that the patient will understand. And how do we begin? Now, one, we find out what the patient's problems are, and we listen to their concerns, their beliefs, and the needs they have. Now, on top of understanding, you try to bring yourself down to the level of the patient. If, like Thomas was saying, if the patient is talking about mangoes causing malaria, is there any logic to what the patient is saying? How can I bring myself to the level of the patient to understand what the patient is talking about? And like Thomas was saying again, you find that during the rainy season, it's the mango season, there's rain, the mosquitoes are plentiful, so malaria increases. And now this brings a new dimension to what you've brought. You've come with messages to prevent malaria, but you've found something else. Well, initially you may have come to say, let's spray the mosquitoes, but the patient telling you mangoes. So you've got a new dimension to what the patient believes. You've now brought yourself to the level of the patient. So step number one is bring yourself to the level of the consumer, listening to their beliefs, understanding their culture. Now, after understanding, you have to marry your message, intertwine what you brought with what the patients believe. If, for example, you brought spraying, you have to factor in the fact that the people believe mangoes bring malaria. So how am I going to marry my message? With the mangoes. Now you have to come again to explaining. I mean, you see a patient so and so, we have mangoes during the rainy season. During the rainy season, we have a lot of mosquitoes, and eventually the patient will see a connection between mangoes, malaria, and mosquitoes. So, well, you've brought yourself to the level of the patient, you've translated your message, you've married your message with what the patient believes. Now, on top of that, you have to design the tutorials. Now, I'm bringing the tutorial because it's what we've been doing. Now, that's the message we've been passing on. We've gone to the level of the patient, listened to the patient's concerns, understood their beliefs and concerns, and then married their beliefs and concerns with what we're exporting to them. Now, what are the tutorials? The tutorials are basically a tool to make the interventions available for everybody to use. We've found something successful. How can we make it available to everybody else to prevent malaria, to prevent disease, to improve health in Africa? And if you've translated the messages to something that can be understood, basically bringing medicine, healthcare close to the people. And that's what we're doing in the Mifumi project. Basically translating health information to something that can be understood by the patient, by the consumer. Thank you very much. I would like to now hand you over to my colleague, Deborah Chige, who is going to talk about health education in children.
Thank you very much, Nixon. As he has introduced me, I'm Deborah Chige, a fourth-year medical student. And yes, the newest member of the team of students. My particular area of interest is women and children. Well, as my colleague has mentioned earlier on, the age group most affected by community diseases, particularly malaria, are the children under 5. And in most cases, they present to hospitals with complications that could have been prevented at the community level. In Fumi, the population was, the percentage of the population that were women was approximately 70%. Percentage of children, I'm not so sure, but I believe women are pillars in families, women are pillars in the home. And if you are to educate the rest of the family, to educate the community, you need to get to the women. And I believe prevention is better than cure. Thus, our target has to be at grassroots level. One mode of getting health information to the women is through their children. In Uganda, we have universal primary education, which means every child is entitled to education up to about grade 7. And so, an effective way of reaching the children is at the schools. Nixon mentioned earlier on that we have packaged the information on malaria in the handbooks in a way the community can understand. And I believe we could go a step further in packaging the information in the handbooks in the way an individual can understand. In particular, the children. So, towards the end of last year, I was involved in the community-based education, and we went out to a place called Chiboga, and our target group was mainly the children, educating them. So we took the package, and from the package we created songs and poems, and using visual aids, we creatively communicated the causes, preventions, signs and symptoms of malaria to these little children. And what was the effect? Well, awareness of malaria, causes, signs, symptoms, prevention, and seeking treatment was communicated in a language they could understand. And these young, eager minds would take this information back home to their siblings, to their parents, to their friends, telling them about malaria, telling them about the signs and symptoms. And supposing one of these children did fall sick or their sibling fell sick, they'll be in a position to identify the signs and symptoms before the complications came about, and thus urge their parents to take their siblings to the hospital. So as has been said and is very clear, the communities have the knowledge about malaria. They know. But we believe that to reinforce behavior change, we need to educate the children because they are our health messengers. Okay, yes, I'll now hand over to my colleague.
Good time. Who is next?
Brian.
You can stay here. No, it says you can stay here. Yeah. Who's next? Yeah, you can stay here. Him.
Okay, thank you. Thank you. Yeah, this is Brian. This is Sekayombia Brian, a pharmacy student, year 3 at the Faculty of Medicine, Makerere University. Yep, like the previous speakers, all what they said was about the malaria, what they've done in the villages and all that. Then I'll talk about what do people do, the community perspective. I'll give this according to the results we got from Me4Me, the project we did at the beginning of this year. I'll give in that direction what those people do when they see they have the signs of malaria. Like they said, some of them know the signs. Some don't know, but some know. Then what do they do after? Since I'm a pharmacy student, I'll dwell so much on the drug side of it. I'll come a little to the social part of it. First, these people in Me4Me, it so happens they have ideally one health center, one active health center in a diameter range of about 6 or 7 kilometers. That is one health center that can help them around. So they really get really hard problems to get to the health center. So, and in the whole community, there happens to be one drug shop, which is operated by, I think, a dispenser. Now, these people, when they get the few signs of feeling weak, like that, those are signs they know, because, I mean, they've been told by some people know, others it's just a myth, like when you get some small problems, you go to the drug shop. So at the drug shop, it so happens they get the easiest drug that is available and the cheapest, which is Panadol. I think in the US it's called acetaminophen. That's the drug. Usually, Panadol happens to be an antipyretic. So when a person is feeling a little some fever, when you take it, the fever will go down. But doesn't mean you'll have to take the malaria. So these people buy the Panadol, they take it. They usually add on Septrin, that's cotrimoxazole. They usually add it on. So cotrimoxazole has a sulfur component which tends to kind of suppress the malaria parasites just for a small time. So when you take it in the first place, just take it when you really have those chills and all the signs of malaria, you find yourself that all the signs will recede and you think you're well. So basically that's the first thing they usually do when they get sick. But when after some time they find that they're getting worse, rarely got from a few people that they'll associate these problems with spirits. And Me4Me happens to be a place where there was one of these political fighter, I don't know, freedom fighter who was so much spiritual based. So they still believe that that place is being haunted by those spirits. So a few of the people believe that those spirits might have attacked them.
However, still they run to the drug shop and they try to get the Septrin and the Panadol. It's the commonest drug they first buy before they run to the health center that they have. So when things fail, now this happens, they first keep at home, continue taking the Panadol, continue taking the cotrimoxazole. When things become really worse, that's when they can traverse the journey of over 7 kilometers, 432 to the health center. They get to the health center, their malaria is really in high grade. They come to the health center, when they reach, they are supposed to be given anti-malarials, but you find that in their state at which they present at the health center, you just have to go to second-line treatment of malaria. Rarely will you have to use first line because this usually come with plus parasite load of around 4, 3. That is when they've really waited so long at home. So you have to first just give out IV quinine. But now the health center they have cannot admit. So you're forced to give IV quinine, that is intravenous quinine. Then at the end of the day, you'll have to give maybe tablets. But then you find that the tablets of quinine, dose of quinine, the tablets are too many. Not too many as in it's really a full tin, but at least too many for a person to really adhere to them. So these people will usually take the IV quinine, then you send them back home. But now when you send them back home, you'll find that they'll take the tablets for the first day, second day, and so long as the signs disappear, they stop. And they keep the drug for maybe another recurrence. If you subject them to injections, now because of the distance they have to travel, I'm giving all this according to what we got from that community. Because of the distance they have to travel to that health center, you'll find that if they are to come back for injections every now and then, you can't miss, as in, you can't have them to have all the dose complete. That is out. It can never happen. They'll come morning, come in the evening, they can't come the third time because it's supposed to give them 3 times in a day. They can't come back. Then the next day, they come in the morning, then they can't come in the evening, meaning they've come once. So in other words, at the end of the day, you find that you're doing nothing. So you're just forced to give tablets, which tablets still they won't finish. That's what happens. So at the end of the day, you discover that there's been very little knowledge about why they should complete their doses and why they should rush to come to the health center in time. Those who have the little knowledge, because this place has a people who have gone to school, they come to the hospital in time. But now when they come to the hospital in time, it so happens that in Uganda, we happen to be using our first line drug, a combination of artemether and lumefantrine. That's our first line, having ceased out chloroquine, which has gotten a lot of resistance because of the problems of adherence and so many things. We find we've gotten so now we're using artemether and lumefantrine combination. But now the people who come to pick it, yes, they come and get it. It's very, very available at the health center. They get it. But now when they get it, they take it home. Now, from about 5 out of the 10 will admit that, most especially the adults, they share that drug with the other family members. And this is exposing this drug to developing a lot of resistance. How is it coming in? You find that the resistance is coming, if you take a drug not to its full amount, you're going to expose these parasites into developing resistant strains, meaning that drug resistant strains to that particular drug. So meaning that now also our first line, like the chloroquine, may within a short time, if nothing is not done quickly, be also ceased to be, it will become resistant to the malaria. Good enough, the quinine has not yet shown any signs of resistance, but at least the Coartem there is good. Coartem is the brand name of the artemether and lumefantrine combination. Is going to develop a lot of resistance in that case at least. That's what I found. It's going to very soon. It's not going to take long. So now, because of that, that's sharing. So otherwise, I discovered that in this place, by the way, they have a very good audience. These people have a very good audience. So if we can reach out to them tell them the importance of having high resistance, of taking full doses of drugs, such that they can learn. A lot is done at the hospital pharmacy. You tell them what to do, but at the end of the day, it's like it falls on deaf ears. However, the community has a very good audience who are willing to take in what you tell them. So I believe that it was so good when we got into there and we discovered that if you tell them, they can do what you told them. So I found that was really quite a good thing for the people, and it can change a lot about the compliance and adherence to the drugs in that area. Little is done about herbal medicine. They don't usually believe so much in herbal medicine because they've tried it all and it has not really worked. Yeah. Now I'll give a handover to, this is Ronnie Chiwewa, who will give you his talk.
Thank you so much, Brian. My name is Ronald Chiwewa. I also attend the medical school and I'm currently pursuing my 4th year. Now, in most of the community diagnosis carried out by my colleagues who managed to visit upcountry sites for their community-based education and services, they discovered that probably second to malaria, diarrheal diseases really appear to be causing mortality and morbidity among individuals in rural areas. So my task here today is to talk about diarrhea in a health center and with a reflection on where does the problem come from as an insight into what has been proposed to be the second tutorial for Midline Plus in conjunction with National Library of Medicine. So using MIFOMI as a case study, I managed to be together with my colleagues in MIFOMI, and what I'm going to say is based on MIFOMI as a case study as a typical village setting. So first, we need to highlight what has nature put in place for people, villagers like those of MIFOMI village. And these are the problems mainly. One, there are no protected water sources in these villages. We managed to take a tour around the village basically, and what we saw were unprotected springs with water. I'm very sure you have not seen flow out of your taps at any one time. And this water is drawn by jerrycans. I don't know what to call them, the plastic jerrycans. They draw the water. I think at a later time you may have a privilege to look at some of these photos. We took them. And what makes it more absurd is that these unprotected water sources are shared also by the animals that come to drink water there. So you can see this will predispose the people to suffering from these diarrheal diseases. Second, people lack the basic knowledge of avoiding diarrheal diseases. For example, the fact that they have to boil their water and keep it safely before they can drink it. Many of them think that since the water they get from the well is dirty, they only need to sediment it in a jerrycan somewhere for 2 to 3 days. When it turns clear, then it's safe for drinking, which we all know is wrong and could predispose them to getting diseases. Others think that even when the water is boiled, storing it in a jerrycan is enough, yet it may not be enough. You need to clean the jerrycan regularly. So this basic information, this basic knowledge, the people do not know. So this reflects on the point of ignorance. Ignorance and illiteracy. Many of the people have not gone to school, and unlike you and me who have gone to school, they do not have the advantage of knowing how these germs get to them. So it should be very important. We need to combat this ignorance if people are to avoid this, if we are to prevent these diarrheal diseases. Then very important is the fact that the people are poor. Even when they identify the signs that they think are characteristic of diarrheal diseases that need intervention at medical centers. For example, in Mufimi where we were, there were people who could not afford baseline investigation, laboratory investigations that cost around 500 Uganda shillings. That's less than 50 cents of, if you talk in terms of the US dollar, you see? So once these people are so poor as to afford these health services, they won't seek them. And if they don't seek them, they and their children will die from these diarrheal diseases. So what should be the interventions? Interventions should be tailored for these people to acquire the basic knowledge in preventing diarrheal diseases. Knowledge about washing fruits before they can eat them. Knowledge about washing and keeping their utensils clean. Knowledge about the significance and consistency of cleaning and maybe smoking latrines to eliminate the what? The house flies that are very important in spreading these diarrheal diseases. 2, it's very important to identify and manage early diarrheal diseases. So people should be told the basic signs and symptoms of these diarrheal diseases. If there were ways of showing them how rice water stools look like, so as so that they can deduce what cholera is, or red water stools so they can tell what dysentery is, this would help in the curbing of spread of breakouts of diseases. So again, if all were possible, these people should have protected water sources so that they can have different drinking places for the animals compared to the places where they draw their water. And if it were possible, there would be IEC materials, information and education communication materials, passed out to these individuals in the languages they best understand, with information regarding proper methods of avoiding and preventing these diarrheal diseases. It's very important to combat ignorance. So people trained should go out there and preach to the villagers about the causes of diarrheal diseases, about the signs, symptoms, and the best methods of avoiding them. And this is where a program like community-based education and services comes in, because the students at the Faculty of Medicine have this basic information, and they can be, I think, the best weapons to pass it over to the villagers as they go to pursue this part of their curriculum in the villages. And finally, I think poverty should be converted, because if people fear to approach health centers because they do not have the money to subscribe for health services, then they are going to stay out there, die, and enhance the spread of breakouts if they so happen. That's basically what I had to tell you about diarrhea in the health center, and I will introduce my next colleague with whom we attend the same medical school to tell you about Midline Plus tutorials as a behavioral change experience. He'll give you his COBS experience and ambitions as a young man in the political field, probably. Thank you.
Thank you very much, Chiwa Ronald. As he has already told you, I'm Nelson Igaba, fourth-year medical student, and I'll be talking about Medline Plus tutorials influencing behavior change in the community. I happen to be one of the medical students who have benefited from the COBS. My colleagues have been talking about it, community-based education and services, which is a program that really allows us to go closer to the community, to reach the people who would find us in the hospitals or the health center would serve in at a later stage. So we, as my colleagues had said earlier, we designed a kind of a tutorial which has visual aids about malaria so far. We are planning to design more, of which I think we are through with the diarrhea one, which will be out soon. Basically, what we talk about the tutorials, they are visual aids that have some few words which are targeting the common diseases in the community. We came out when we did a study in, I think it was in 2006. It was around the shores of Lake Victoria, that was in Kirudu, a village called Kirudu. We found out that when we used to go to the community to talk to people about the diseases in that community, they would not understand us just by the mere words we're using. because we used to use a lot of English from the textbooks that are written from the West world, and they could not understand really what we're trying to mean about malaria, about mosquito, the parasite, plasmodium, and the rest that concern malaria. So we found that it will be best to design a tutorial, a visual aid that has few words, but has images, that these people would look at an image and relate it with the meaning of that image. So that is about the tutorial. My experience in the different sites I've visited, starting with the one, I don't know if you're still getting me that side. Okay, starting with the one on the shores of Lake Victoria. You know, that place is so swampy, and their common problem is malaria. We found out that people believed that malaria could be caused by witchcraft. Witchcraft, this side is where they believe someone can, I don't know if they understand witchcraft. Someone can, is it poison you or something, spirits and the rest. So they think that some people will be jealous or they're against them, and they would make them get the malaria. So we went ahead and educated them with these tools. These ones are modified one. We had others that were not modified to this level. So we went there in the first week. Then after 5 weeks before leaving the community, because we stayed in the community for 5 weeks, we used the last week to go out and see if what we said in the first week was put in practice. And at one home, when we went there in the first week, we found out that they had a maize plantation just at 2 meters from the main house. So we told them that this maize plantation will harbor mosquitoes. Okay, and this mosquito will just fly through the windows to their home, to their rooms, and these people will be bitten by mosquito and get malaria. Lucky enough, the maize were in the end stage. I mean, they were ready for yielding. So we found out that these people had already yielded the maize, and they were planning to plant it at least 10 meters away from the home. So it was an encouragement to really knew that our message is being taken home. Apart from that, we visited the homes, and we found some homes didn't have toilet covers. So in the last week, they made toilet covers out of wood. Just they prepared wood and they made a toilet cover. Though it could not fit well, but we could really see that the message had reached home. Then another experience was in the eastern part of Uganda, that is Iganga, a place called Iganga. We went to a school in our first week there, and it was a primary school. And when we visited the school, we found out that we're talking about diarrhea and malaria. So these visual aids will help us in children, because primary one children here could not understand the English, they could not understand the parasites. So what we'll do, we'll show them where there is a drawing of a mosquito biting someone, and how this person depicts with the signs and symptoms, and they could really flow. At the end of the day, they will generate a song out of the whole of that tutorial. So which was another good experience. The other one is about the same place, Iganga. We went to a secondary school, and after a talk with them, we told them that we will be on the radio the next day. So the same people we talked to the school are the same people who called in on the radio station. So asking more questions, which really gave us an opportunity. When we went to the radio station, it gave us an opportunity to give the same message we had given to the schools to a big area covered by that radio station. So the good thing about the Medline Plus tutorials are that they relate to the culture in the particular community. What do I mean? Like here in Uganda, we commonly use pots to keep water, okay? And this is clean drinking water, pots. So in one of the pictures we have of diarrhea, we are relating a child who has diarrhea to a pot that is leaking. That means that if this child has continuous diarrhea, it will be like this pot that has a hole down. This pot will get empty, and which will mean that this child also has continuous diarrhea. the child will get dry, what we'll talk about dehydrated, and at the end the child will die. Okay? Then we also found out that these things that relate to the people's culture, people understand them very well. Like Julia told us that they found out like in West Africa, people don't use coffins. So you can't tell people about that. Like we have a drawing here of, I don't know if you can get it, of a pregnant woman equals to a coffin if she gets malaria. Meaning that when a pregnant woman gets malaria, she has high chances of dying. So we find that in West Africa, you cannot use that kind of illustration because they don't use coffins. But here in Uganda, we bury people in coffins. So we find that Medline Plus tutorials with visual aids, they help people down there understand, really relating visual images to the particular things on the ground. Lastly, I'll talk about the political kind of intervention that has been there in Uganda. People in the villages, they look at these politicians, they think that always when they come to do interventions about malaria and other diseases in the community, they look at them as if they're coming to do research, okay? And they don't take much of what they say. Whereas when we people go there, we get down to them, we become like their children, so we sit down with them and we learn from each other. We accept their culture, they accept what we tell them. So that has generated negative attitude about all interventions that are brought out by the government. Like the mosquito nets. Some people just buy mosquito nets because they are being put on pressure. Some people just dig garbage collection pits because they told them that we don't find a garbage collection pit here tomorrow, we shall imprison you. But when we people go there, we tell them the use of the garbage collection pit, how it will help them prevent against the diseases. They will understand better other than being put on pressure by law enforcers. Then I think I should really appreciate the Medline Plus tutorials and my involvement in the project in collaboration with National Library of Medicine, because it has really encouraged me to build an ambition. I think when I become the Minister for Health of this nation, I'll use the same idea to intervene into common diseases than just enforcing laws on the people in this community. Thank you very much.
You will be.
Thanks to all of the students.
Julia, that was great.
Roger, just wanted to let you know that a couple of other people have come into the room, one of whom you know, Dean Nelson Sewan Kambo from the Faculty of Medicine has come in and heard the students. Too late to introduce, but there he is, saying hello to you, long distance. So we're glad to have him with us. Also, as far as the Mifumi project is concerned, we now have with us Dr. Joseph Ojwang, who's actually with the Walter Reed project, the AIDS vaccine clinical trial here in Kampala. And he is the one responsible for hooking us up with this interesting village in eastern Uganda that you've been hearing about today. So we're delighted to have them with us. I introduced Dr. Monica earlier, who is head of the COBES program and doing a wonderful job of creating this opportunity for students to really go beyond the walls of the medical school and out into the community. Now, please, Roger, take over. You guys were open for questions. You can talk to any of the students and just fire away.
Sure. Julia, this is the first time we've tried this, and we're absolutely delighted to see the enthusiasm of the students, and we're ready to elect Nelson Igaba as Minister of Health in the future. We could do a fabulous job. And it's lovely to see Nelson there, because Nelson, in our strategic plan, we would love to see much more of this interactive activity between us at Fogarty and your students. I think it puts a reality in what we're doing. So we are delighted with this presentation. And while we have a few glitches, we see a great opportunity to extend this. The presentations that you kids did were wonderful. And I think that, you know, we sit here at NIH, and I'm going to let Tom Williams talk. Presentations were great, and you're talking about things that we would never appreciate unless we were out there slogging in the fields and living with you in the village. So some of the observations, the cultural sensitivity, the not using coffins so that the sensitivity to the material, the relationship with mangoes and water or bushes, the idea that we have this huge program now to introduce bed nets, and people have to understand why to use bed nets, the mosquitoes' involvement, the time to use bed nets, the fact that the bed net has to be over you and not on the floor or as a dress or something. There are lots of things that you're going to learn from this community education program and the Cove's experience. So it's an experience that perhaps we should be using here in the U.S. and it's one of the lessons that you can give us to take back home. So in fact, we're learning from your experience. I don't want to talk too long because I'm surrounded by wonderful people. I've got Tom Willems, who's in charge of the intramural program. I'll let him say a few words.
Let me just...
Onesmo Olemoy is going to speak to a larger group in a few minutes, and I would let him say a few words before we have to run off to his talk this morning. And then I'd let Joel Bremen and our other visitors give questions, but I may have to leave to introduce Onesmo at 10 o'clock. Tom, why don't you say a few words?
Well, yes, let me tell you how much I enjoy hearing that. All of you have put in a tremendous effort. I have a notebook here, and usually when I listen to something for an hour, I will make just a few lines to remind myself that I was listening. But here I filled up 2.5 pages from all of you with your words and your comments. It was wonderful to hear. I work quite a bit in West Africa and Mali, and so much of this resonated with what we see there, and I see in your solutions, in your approach, a lot that we can learn there and apply. Let me say also, Julia, it's been too long. I enjoyed hearing your comments as well. I do have one question for you, and maybe Brian can start with some comments on this. And that is the issue of non-compliance, or when the patients take these medicines home and they share it with their families, or they might put it on the shelf and wait for another episode, which might come, within a week or two because it's an incompletely treated malaria, or they may take the medicine and they might barter it for some chickens or something. So I'd like to hear more. What approaches do you take to improve compliance? How do you encourage these individuals to complete the course of medicine so they rid themselves of all the infection?
Thank you. It so happened that you discover at the health center, you meet so many patients at the same time. So you don't have almost all the time to explain to the patients all that you should have done as a pharmacist in there. But we discovered that a home approach, home-to-home approach, then even maybe a group approach where you meet a group and explain to them about a particular drug, how to use it. It really changed a lot of people's attitudes, and it kind of showed some improvement in the compliance among the people. Going out to the people and maybe meeting them in groups and really telling them, because when you get into their homes, they feel like you're part of them, and believe me, they will take all that you have to say, and you have all the time, they have the questions, they have everything to ask. Usually they fear to ask in the hospital, but when you go out to their homes, they really have the time to ask you. They make a cup of tea, you discuss things, believe me, they will never forget them. When you meet them in a group still, you interact with them so freely, and they will have to learn more, and they can ask questions, and believe me, it changed something about their attitudes about giving drugs. By the time we left, believe me, all of them were not into buying Septrin again for malaria, at least the people we met.
Do you have teams, guides within the 6-kilometer radius? Maybe they go on the motos, and what is the population? How do you cover them and follow them?
Yeah, we were there for quite some number of days, and we had a guide who used to take us quite long distances, by the way.
Not on a motor.
At least not on a motor, we used to walk. We feel that we should be part of the community, so you walk with them, you laugh with them, and then good enough the homesteads are a little in the secret areas, as in a length of about 100 meters, 200 meters from one home. So you go meet home by home, you meet, and believe me, wherever you go, you have to take a cup of tea. So one day you're here, the next day you're there. At the end of the day, you've covered quite a good number of homesteads.
Let me just ask Onesmo Olemoye to speak before I drag him off to his 10 o'clock lecture. Onesmo.
Yeah, thank you very much. I would like to congratulate Julia and Makerere University and the students for doing what you're doing. I think it's extremely important to involve the communities in any health interventions that you may bring. In this connection with malaria in particular, it's important for the people whom you are trying to help and whom we would like to help to have a basic understanding of what malaria is and what they can do to control the disease. One of the main things that I think you need, the message you need to get across to people, is the fact that a substantive amount of malaria is actually caused by what people do. One of the worst things in sub-Saharan Africa is plastics. Everywhere you look, and I know I've been to Kampala, Entebbe, in Nairobi, mosquito breeding sites are a main issue, whether you're looking in the rural areas, in the peri-urban areas, in the urban areas. People provide sites for mosquitoes to breed. And if you're going to talk to the people about the control of malaria, it's very important to be conscious that they are providing sites for mosquitoes to breed. And the community can contribute by making sure, as one of the students was mentioning, that you remove plastics, you remove cans, you look at places where there's standing water to make sure you minimize breeding sites for mosquitoes. But what you're doing is fantastic, absolutely fabulous. It doesn't matter what solution science comes up with. To learn from the community and to make sure that you get their involvement in all these interventions is completely critical. And I'm delighted to note that you make a connection between malaria and the diarrheal diseases. Some of these diarrheal diseases also cause anemia. And if you treat only malaria and you think you've solved the problem and walk away, ignoring the other problems in the community, you will not have done your duty. So congratulations. Please continue what you're doing. You're doing the right things, and I'm delighted to see this. Thank you very much.
I'm so glad you could be with us, and hopefully I'll see you here or there in Nairobi or here in Kampala. I was talking about ECP just the other day because we visited a citronella factory here over in Tororo, near Tororo. And the idea was that, of course, what ECP has been preaching for a long time, that citronella can have a deterrent effect on mosquitoes. So you're always in my mind in terms of the innovation that goes on at your center.
Well, one thing I will say, Julia, to you, is that you have become more nomadic than I am. So congratulations.
I'm going to pluck Onesmo on, but you can continue with other questions. Thank you, Julia. This was fabulous.
Fantastic.
Thanks, Roger. We'll do it again.
Okay, the other question here. There's another question.
Hi, Julia. Joel here. Congratulations.
Hey, Joel.
Hi, good friend. I can only add my great congratulations to you, in particular to the Dean, Dean Nelson, for giving us a spectacular example of how a medical school takes learning out into the field, into the community. We need more lessons here in the United States, so please come here and go from school to school to show how gown can be taken to town. What I was very impressed with from our young colleagues was their focus on proper quality of treatment. You know, all of the big organizations talk about coverage, they talk about access, they talk about use of drugs, but you talked about the quality of treatment, being sure that the drugs get into the patients in the proper dose. We had a pharmacy colleague who I'm sure is very aware of the fact that sometimes we have sham or counterfeit drugs which are distributed. So I have a question, is that an issue in Uganda? And do you have a means of checking to be sure that the drugs, not just for malaria, but for other things, have the proper potency, sterility, and durability that you want? So that's the first question. The second question is, in your marvelous brochure, you have that there are 70,000 to 110,000 deaths from malaria every year in Uganda. That's over 10% of all the deaths in the world. And you have a student or a team looking into that to be sure those numbers are accurate, because I'm sure Uganda is going to be leading the world in defeating malaria before any other country, due to the interest and enthusiasm that you've shown today and that your program is showing in its activities through data I've seen at UNICEF. So I have those two questions.
Okay, thank you very much. I'm discovering drug problems are everywhere. Okay, now in Uganda currently, we've had very little incidence of fake drugs. I think there was only one incidence of a recall of a drug from the market. That was about 3 to 2 years back. However, we find that we have the National Drug Authority, which makes most of the drugs authentic. Little drugs get in here when they are fake. The biggest problem is having expired drugs on the shelves. And this one comes in basically in these small, what we would call drug shops. They're really small, like retail shops for small medicines, across the counter medicines. That's why you find a problem of they have expired drugs which they dispense to the people. However, at the hospitals, the hospital usually has a pharmacist, and who is supposed to check whether all drugs that are being given out are authentic. And you discover that most of the drugs that are delivered into the hospitals are usually delivered from national medical stores. That's where most of the drugs are, national medical stores and the joint medical stores. So those drugs come directly into the hospital. And usually these hospitals receive those drugs which are first verified by the National Drug Authority. So little is experienced about fake drugs and authentic, as in drugs which are not authentic. But for expired drugs, you'll find them, but in drug shops, rarely in hospitals. Very rarely. Thank you.
Okay, the second question was about one, whether the figures are accurate, the figures represented in the manual, and whether we have a team of students doing something to reduce the prevalence, the incidence of the mortality from malaria, basically. And the answer to that is, well, about the accuracy of the figures, 70,000 to 100,000, well, we're baffled as you are, and that's why basically we went out to the community, did a baseline survey, which my colleague Thomas ably talked about. And the aim of this baseline survey was to establish, one, the mortality of malaria, from malaria in that village, and basing on that mortality, to see if we can make a difference, we can make a change in the local community in Mifumi. And of course, the aim of the tool was not to be kept on shelves or to be seen to be doing something. We actually went out to the community to use the tool to reduce the mortality from malaria. And in the long run, through the collaboration, of course, with the community-based education and services, we hope that the tool can be taken to the country and to every district to prevent malaria, to reduce the deaths from malaria. And of course, our hope also is that Uganda can be a shining example to the rest of the world in preventing malaria. Thank you very much.
To Onesmo's talk, but we're going to send you copies of the new American Journal supplement, Julia, to distribute there. The students are spectacular, and I'm sure they'll be adding to the next supplements on malaria and many articles to the international journals with their marvelous work. Thank you. Marvelous.
Hi. Good morning.
I guess we sign off at this point. I'm not sure if we still have Rob and the folks at NLM.
This is Ion Austin Rob.
There's another question?
Yes. You have time for one more, Julia? Good morning. Good evening. My name is Del.
Yes.
I am a staff writer for the NIH Record. I'm also a nurse. And I'm extremely impressed with all the work of the Makerere research team. Thank you, Julie, for inviting me. I have a quick question. When Julie reported on her midterm here at NLM, I was able to cover it for a newsletter for the NIH campus here alone. There are 18,000 people. I think I heard you say there was a reporter in the audience there. And I was wondering if you were getting any local coverage of all your good work.
Well, there is a reporter. There's a reporter here, Belle, and it's good to see you, good to have you. The students loved seeing the article. And the reporter is from the New Vision. And actually, we're hoping to be able to create some kind of partnership with the New Vision so that we can get these kinds of materials, the tutorials, out to even more people. As far as coverage of what the students are doing, we very much love that, and we hope that our colleague here today can be helpful along those lines. Did you want to say something?
Hello. Okay, thank you. Okay, I thank Julia and the team. Yeah, of course, my name is Frederick Omakiu. I'm from the New Vision. I'm a writer with the New Vision Health section. Okay, we are trying as much as we can to make sure that at least we cover this. And that's why we are here today, and we are doing it. So we are not leaving them out. Thank you.
Hi, Julia. Yes, it is. Rob had to leave, but I just wanted to say a few words from NLM. Asante Santa, we really enjoyed seeing everyone on the big screen at the National Library of Medicine. And I want to second what has been said earlier. We encourage you to publish your experiences and insights of working with your communities, and also your experience in creating tutorials for Medline Plus. And also, I'd just like to say that in paraphrasing Dr. Michael DeBakey, who's an esteemed member of the NLM Board of Regents, education is good medicine. I think you're proving that. Thank you.
Thanks, Ione. And next time we'll make sure that the librarians are here to join us as well. Ione Austin at the National Library of Medicine has done incredible work with African librarians, keeping them in touch with one another and in touch with us. and we look forward to engaging them in the next teleconference. Ione also lived and taught here at one point, so for her, I hope she wouldn't recognize things today.
Well,
thanks so much, everybody.
Just one other thing, we have the NLM MIMCOM webmaster here, Andrew, and I know that he would like to be involved very much with any further work with the teleconferences.
Absolutely. Hi, Andrew.
Hello, Julia. How are you? You see me?
Andrew Plummer has worked with the Ethiopian librarian project we're doing at in Ethiopia, the Addis Global Distance Learning Site. And so we have experimented some there with teleconferencing, and I'm glad that he wants to be involved more on this end. That'd be great.
Oh, it's nice to finally see Nelson, William, and Nixon. I mean, they're kind of like a little bit famous here because of the videos on the Medline Plus site. So, wow, it's like a real pleasure seeing you guys in person almost. I'll just say that the tutorials are doing great. Keep sending us information. We really want to keep working with you guys. Just keep pushing it out there. Definitely want to keep going with particularly the diarrhea tutorial. Any new materials you can send us, any revisions, just keep sending them. We'll keep reviewing them. We'll just kind of keep putting these things up. And thanks so much, guys. You're doing absolutely wonderful work out there.
Thanks, Andrew. Well, if there are no more questions, or from anyone at the two sites of the site here, any questions, comments, observations?
We insist.
Would our dean like to have a word?
Yeah. The dean didn't want to say anything, but the students insist. Yes. This is indeed a great experience for us here. This is, the first time that these kind of tutorials are being done for Medline Plus, and a lot of tribute to not only the students, but to Julia, who initiated this. I hope, and I really hope that we can keep this going over the decades to come, and we keep improving this. It will make a tremendous difference not only to the education of our students in terms of how they relate with the delivery of interventions for our community, but in the long run, the expectation is that indeed the health of our people will improve. So thank you very much for your contribution.
Well, I think the dean has the last word. Goodbye to everyone. Thank you so much, and we hope to see you again on the big screen.